So today I hope to take you through a short tour of the hearing system up to the brain and talk a little more about what it means to hear, but what do we actually mean when we say, are you hearing me? Right? There's a lot involved in terms of cognition, memory, when we have a simple conversation with someone. Okay, so what does it take to hear and understand, remember, and respond? What's our research showing us in terms of hearing loss, treated, untreated, and how that affects the brain? And if we diagnose hearing loss, when should we consider hearing aids? And what are we continuing to learn with hearing loss in the brain? All right, and as Chelsea mentioned, please post your questions, whether with the Q&A button or the chat function. Chelsea is going to compile any questions during the presentation, and I will do my best to answer them at the end for you. Okay, so we're going to take a very, very abbreviated tour through the ear up to the brain. We could do whole presentations on this, of course, but important for this, the course of understanding hearing in the brain, we have to get sound from the outer ear and the ear canal to the middle ear. Three little bones in the middle ear conduct sound to the inner ear, where we find the hearing nerves. Okay, this is where majority of hearing loss occurs, in the inner ear, whether that's due to genetics, noise exposure, ototoxicity for medication. Most causes of hearing loss are in the inner ear. That being said, we're neuro-otology practice, so we see quite a bit of outer and middle ear hearing loss as well. Of course, proper diagnosis of the type of hearing loss you have is step one in getting treatment. Okay, but today we're going to focus on the inner ear up to the brain, and just knowing that even after you detect or hear a sound, there's still a lot of work to be done in the brain to process what's going on, make it into language and response. All right, so I'm going to start with just a little exercise, something for you to think about throughout the presentation. And for those of us that are, listening on behalf of a loved one or know someone with hearing loss, I always ask my family members to think about this. If you're listening to a TV program or a talk radio, and you're understanding half of what's being said, how likely are you to keep listening to that program? All right, it takes a lot of effort to decipher and to want to keep listening. Okay? So I always tell my, family members, spouses, it's hard to continue to listen if you're having trouble hearing. So keep that in mind when you're asking someone to just listen, right, with hearing loss. All right, so what does it take to hear someone speak? All right, a lot going into it. So first, the brain has to localize or find the sound, see who's talking, right? You have to translate the sound into words, process it as language, use our short-term memory to store the words that have been said, and at the same time, conserve cognitive energy and resources to pay attention to other things in the conversation, the body language of the person you're talking to, the tone, their intention for the conversation. We need to do all that, hold on to it, and then produce a response that makes sense. All right, so sometimes some of these factors are much easier. If we're localizing, finding the sound, the person's right in front of us, that's pretty simple. But if they're yelling from the other room, we have to first find out who's talking, where they are, so that we can then focus and attend. Okay. And you should also note this is all about speech, but we do a lot of other things with hearing, namely, survival-wise, where our brains are wired to pay attention to sounds and not pay attention to other sounds that are less important. So if there's a lion, sound behind you, you're more likely to quickly turn than if it's someone we're familiar with. It doesn't seem as important. So there's definitely that fight or flight response in response to some sounds. And also the emotional piece of what we're hearing, a lot of music appreciation and sound therapy, all these things are very different than speech. And the brain is, there's parts of the brain that sign, emotion, or a reaction to sound. So that's all going on too. And then balance. We do know that, when we're aware of our environment in terms of having hearing cues, right? It makes us better aware of the environment, and studies have shown that wearing hearing aids or having good hearing versus untreated hearing loss can actually help improve our physical balance when we have those environmental cues. All right. So if there's one thing I take away from this presentation, I simply want you to understand that the brain generally just doesn't like gaps in information. Okay. So hearing loss definitely creates those gaps. If we think about it as our familiar Wheel of Fortune here, right? Sometimes we're going to have more cues than others in terms of filling in those blanks. And then on, say, the bottom screen here, if anyone can figure this out, I will be extremely impressed. But without context, without knowing the theme of the puzzle, right, it can be really challenging for the brain to fill in those gaps. And for those of you playing along, I hope some of you got the first one. The second one, if you were able to figure that out, let me know. I would be very impressed. Okay, so we know the brain can fill in those gaps that we're not hearing, or, if we're talking about hearing today, this kind of applies to all senses, right? The brain can fill in those gaps, but at what cost? So one, it takes a lot of effort, all right? If you're listening to a whole conversation that you're missing, a quarter of the consonant sounds due to your hearing loss, it's extremely tiring. I often have patients, as you get used to your hearing loss, you get used to what's normal, and it's very slow progressing over time. But a lot of them, when they get hearing aids or treatment for their hearing loss, say, wow, I'm just not as tired at the end of the day. Okay, so listening effort, definitely. And then again, just fewer cognitive resources for other thinking, or, using all of our cognitive resources for that auditory processing of the sound if we're not able to hear it well. So it takes away cognitive resources for other thinking and memory, short-term memory systems. And then, of course, if we're constantly filling in those gaps and not hearing, we know that the hearing nerve, like anything else in the brain, it's use it or lose it, right? So if that hearing nerve is getting stimulated, getting sound, and the brain is getting that sound, those are all good things. Neural atrophy can occur if we're not hearing those sounds. All right. So I mentioned earlier a couple terms in terms of listening effort and this theory of cognitive load. Again, this is a cross-sensory kind of school of thought in terms of having a relatively finite amount of cognitive energy or resources to use for a task. And if we're not getting a clear signal in terms of audibility, we're spending more of our brain power processing what's being said, trying to decipher versus storing that as a working memory and being able to respond appropriately. Okay, so we're kind of always catching up. All right. So if you do a general Google search or PubMed search on hearing loss and cognition or hearing loss and dementia, you will find dozens and dozens of studies across the board, starting in the late 90s, early 2000s. It kind of came onto our radar, and people started looking at these correlations of people with hearing loss are so much more likely to develop dementia, and why is that? So I listed just a few here on for your reference, but as I said, there's dozens and dozens of studies, some of them looking at really big populations in the thousands, population-based studies to see, is this really the case? And what kind of factors can be modified to help prevent dementia? So I highlighted just a couple outcomes here, one being the Franklin study of 2011. That was the first big study that really put this on our radar out of Johns Hopkins. And they have really said that, mild hearing loss doubles your risk of developing dementia, moderate hearing loss 3 times, and severe hearing loss 5 times. So that pattern that we've been seeing was true, and it was more true the more hearing loss people had. So that was a pretty convincing study that really made us start considering fitting hearing aids earlier. Versus before it was, well, what makes sense in terms of audibility, and is the patient struggling? Are they not struggling? But now we really think about it as a proactive treatment option. Okay. Yep, and another one of these studies showed that hearing aid use was associated with better cognition, and that was independent of social isolation, depression, all these other factors that can contribute to neural atrophy rate. Okay, so in addition to just confirming, yes, there's a strong correlation between hearing loss and poor cognition, dementia. Some other studies more recently have looked at fMRI data and other imaging to really look at what's going on in the brains of people with hearing loss, children with hearing loss, people that were born deaf. So there's all kinds of reorganization that occurs in the brain and the cortex that we can now see with good imaging. So that's kind of a new generation of research in this area. One that's interesting I highlighted here, this was in 2020 out of Dr. Sharma's lab at University of Colorado. She actually looked at brains of people with just mild to moderate hearing loss and was able to see that we're actually, even with just mild to moderate hearing loss, the brain shifts to using more of the visual cortex, the visual centers of the brain when listening. Even with the mild to moderate hearing loss, we're already kind of shifting the focus to be able to lip read and use more visual cues instead of the auditory cortex. And then interestingly, they took these same patients that were showing this with the mild to moderate hearing loss, put them with hearing aids and rescanned their brains 6 months later. And I remember her saying she was kind of shocked that that cortical reorganization, or that hearing to vision shift, was reversed after just 6 months of proper hearing aid, consistent hearing aid use. So we know that the brain is definitely plastic and can be reorganized. So that was promising. And then the Lancet report, major medical journal, came out in 2020 with a overview talking about risk factors for dementia, and above all other modifiable risk factors, ranked hearing loss as the #1 modifiable risk factor in midlife for developing dementia. Yeah, so that's more of a risk than hypertension, alcohol use, obesity, all those kind of common things we are warned against. But hearing loss was a huge modifiable risk factor for later developing dementia. Okay, so we have a hearing loss. How does treating that hearing loss support your brain? Okay. So of course, the primary goal of hearing aids is to restore audibility, being able to hear those sounds, sometimes just at a few pitches where you've lost hearing over the years. And once we're able to hear all those sounds at their proper level, the brain typically figures it out and says, okay, now I've got those cues, I can focus more on the working memory and all the processing. That gets harder and harder to do with more severe hearing loss. So generally, my patients that start early with mild hearing loss and get hearing aids fit do much better in the long run with hearing aids, and it helps maintain their hearing nerves so things are clearer over time. But this is a schematic from just actually one of the hearing aid manufacturers that talks about brain hearing and what the hearing aids are doing these days to help support some of those other cognitive processes that we're already having more cognitive load, right, in the processing department. So compared to even 10 years ago, a night and day difference in hearing aids in terms of how clean the sound is, how good the sound fidelity is, but also how well the hearing aid helps your brain sort out different sounds in those more complex environments, right? So the noisy restaurant or the coffee shop with different noise sources all around. they're not noise canceling headphones by any means, but the goal is to help the brain hear through that background noise as a challenging acoustic. So the research on hearing aids and cognition, we know hearing loss and cognition strongly correlated. If we treat hearing aids, if we fit hearing aids, is that going to reverse the trend? And from what we've seen so far, the answer appears to be yes. I'm still looking at lots of different ways to study this and to make sure that hearing aids have to be fit properly and worn consistently in order for this effect to work. So that's always a factor. But yes, the few studies that have come out so far have showed that hearing aids improve episodic memory. It can delay diagnosis of Alzheimer's, dementia, depression, anxiety, and injurious falls in the older adult population. And hearing aids are independently associated with reduced dementia risk when we account for all the other factors, age, comorbidities, so other illness that can contribute to dementia. Hearing aids appear to be independently associated with that reduced risk. And as we know, not only are we helping delay dementia and preserve the hearing nerve, hearing aids should reduce the barriers to communication, improve quality of life. We know all the other good things that go along with it. We certainly have a lot of successful hearing aid users. Again, the earlier you start, the better you'll do. But of course, all kinds of other positive effects of treating the hearing loss early. All right, so in summary, hearing loss we know has a strong correlation with accelerated cognitive decline, and that's independent of other factors, comorbidities. Just knowing that it's the #1 modifiable risk factor in midlife for preventing dementia is huge. I have a lot of patients coming to me these days with a family history of dementia and say, well, I know I have the hearing loss and this I can change, so let's get on it. I think that's very reasonable. The question becomes how early is too early, and when do we need to be a little more aggressive with that. But seeing studies where even mild to moderate hearing loss already has the cortical reorganization, when I tell patients that, they're typically going, okay, well, sooner is the better then, as long as you're motivated to wear the hearing aids, that'll help. And then treatment of hearing loss with hearing aids appears to mitigate this risk, this increased risk of mild, moderate, severe hearing loss, more and more likely to get dementia. And the treatment of hearing loss seems to result in cortical reorganization in a good way. So looking forward, we'll continue to study the impact of hearing aids on mitigating dementia risk, randomized trials, larger groups, what kind of hearing aid fitting is needed. Do we need a full prescriptive, properly fit hearing aid in order for this effect to take place, or just general amplification? All kinds of questions involved in that, but very good to see that preliminarily that treating the hearing loss properly is reversing those trends. We'll continue to study these patients over time. And then the other question is, what's the nerve, what is causing this, right? So other than, the increased cognitive load with hearing loss, and, at the more severe stages, the social isolation, depression, if hearing loss is untreated and we're isolated, all those things are poor indicators for, it can cause dementia, of course. But is there a physiologic tie between the two? Is it vascular? Is it, what's going on in the brain that might also explain this link between hearing loss and cognition? We can look at to see if this pattern persists in unique populations. For instance, in the deaf community, people that have grown up using sign language their whole lives and have a full community and language system. Is that dementia risk, cognitive risk still there or not? We can continue to look at how hearing loss affects children. We know a lot about even just single-sided hearing loss or mild loss and increasing likelihood for children to fail a grade in school, or lots of research in that area. But with imaging studies and such, we'll be able to know more about what's going on in the early brain with hearing loss. And then continued advocacy for hearing aid use and, of course, coverage of hearing aids financially. And check your hearing. I can't tell you how many hearing tests I do, at age 70, and they say the last time my hearing was checked was in grade school. That's probably the norm. So ASHA recommends testing the hearing every 10 years after school age up until age 50, and a little more often after that. So if you can't remember the last time you had a hearing test, good to get a baseline. And then, of course, if anything changes over time, we know what your baseline is. Lots and lots of resources on this topic. Again, a simple Google search will get you a million articles. I've highlighted a few here, and also put up a book of Dr. Nina Kraus at Northwestern. She has a great book that's a good balance of being reader friendly, but also a little more technical than we can dive into today, called Of Sound Mind, Hearing Our Brain Constructs a Meaningful Sonic World. And if you haven't already, you can follow us on social media. We've got a big team of doctors and audiologists. We're constantly posting content, current articles and what's going on with hearing aids, diagnostics. So you can follow us on social media and find these videos on our website as well. And to serve you, we do have the 3 offices in Newport Beach, Seal Beach, and Irvine. I've seen some of you in Seal Beach, but we have all 3 offices and providers help take care of you. So I'm going to toss this back over to Chelsea. She'll wrap it up. And again, please, if you have any questions at this time, go ahead and type them into the Q&A or the chat function so that I can answer them for you.
All right, so as we give you time to form some questions, I just want to thank everyone for joining us for this last webinar of 2022. So stay tuned, like Jackie said, to these channels so that you'll know as we start up next year, what our first topics are. And we'll also send out, shortly we'll be sending out a survey just in case there are any topics that we haven't discussed during the course of this this series so far that you would love us to dive into. Like Jackie said, we have a very large and diverse team of professionals here who manage a number of conditions. So there's always something to talk about. So if you'd love us to talk about something in particular, and just go ahead and keep your eyes peeled for that survey that'll come through your email. We'll also be emailing out the recording or a link to the recording of today's talk, and it will be housed on our YouTube channel as well. So you can just go to YouTube and look at or look up Showhead Ear Associates Medical Group. So it looks like, Jackie, we have some questions, so I'll toss it back to you to answer those. And yeah.
All right. So the 2 questions I see so far are somewhat related. When should I start wearing hearing aids? And can wearing hearing aids damage your hearing if you only have mild hearing loss? Which are both excellent questions. So it depends. When I sit patients with hearing aids, I tell them anything that could have damaged your hearing before will still damage your hearing when you're wearing a hearing aid. Okay? If you're going to a rock concert and you're wearing the hearing aids or not, you have the same risk for damaging the hearing. Okay? So anything you normally would wear earplugs for instance, you would still wear earplugs. When hearing aids are prescribed properly, meaning you've had a full audiogram hearing test, and hearing aids that are prescribed by an audiologist, yes, they're at safe levels. Okay, so wearing hearing aids, even with a mild hearing loss, does not increase your risk of damage. The hearing aids are set to safe levels. there's a maximum power output or maximum that the hearing aid can stimulate. So it's all set to be at safe levels. And whether or not those levels are comfortable, it can be individualized patient to patient. So we can adjust soft, medium, and loud sounds very differently and fit them into that audible but comfortable range. So yes, hearing aids, as long as they're prescribed properly and you have a mild hearing loss, all good things. You're not increasing any risk. And tied to that, when should I start wearing hearing aids? That's essentially the answer we've come up to, is that mild hearing loss, as long as it's you're missing audibility and you have a mild hearing loss, never too early to start. You have to be motivated to wear them, as they say. So most people come in either as a preventative, I know I have family history of dementia, I'm not noticing hearing difficulties, but it'd be nice to hear better in XYZ situation. They're a great candidate. If people come in and they have zero difficulties, very, very mild hearing loss, and we talk about the options and go from there. But we see changes in the imaging of patients with mild hearing loss. So that to me is pretty strong evidence that the sooner the better. As long as there's a lapse in audibility that a hearing aid can correct for, then can't really do it too soon.
All right, it looks like that's it. Not too many questions today, but that's okay. Like Jackie said, we'd love to encourage everyone again to come in if you haven't, get a baseline hearing test. It is really great to have that baseline just moving forward, no matter what age you are. And then after that, if there are questions that you do come up with after you get your hearing test, the audiologists are always happy to sit with you. We also offer hearing aid evaluation appointment where you can get all of your questions answered. So if there are questions that arise, that's a great way to get them answered. And we have audiologists in every single one of our offices. So Irvine, Newport Beach, and Seal Beach. So again, thank you so much, everyone, for joining us. Thank you, Jackie, for the great information. And we will email you this talk. And if you have questions, come visit us.
Thanks, Chelsea.
Thanks, everyone. Bye-bye.